So let's talk about the community that is undergoing a lot of suppression, a lot of segregation, stigma, be it in the judiciary system, be it in the health sector system, be it at schools, uh, even at security systems, the police. That's the intersex group. The intersex, they are facing a lot of challenges, and I think their challenges come because when you look at LGBTQI, the I think stands for intersex, and yet we know that LGBTQI, when you come to Africa and Uganda here, that's a word people don't want to associate themselves with. So putting these people in this particular group has brought them a lot of harm than good, if you ask me. I don't know why they were put there. Maybe because they are part of the minority groups. So, in addition, we find that 2023 Uganda passed the anti-homosexuality law. When you get that, you find that people don't even want to associate themselves with these people, and yet intersex, someone being intersex, is not actually committing an offense against the anti-homosexuality law. So what happens is this. Let me explain the medical bit of it. We have what we call the differences of sex development. Now, differences of sex development, this is a group of conditions in which there is a discrepancy between the external or the outside genitals, that is to say the penis, scrotum, vulva, labia, and the internal, which is the inside genitals, that's the testes, vagina, ovaries. That is it. That there's a mismatch between the internal genitals and the external genitals in this particular group of people. That's differences of sex development. And then intersex is just an older term to mean differences of sex development. Now, differences of sex development, we normally abbreviate it as DSD. So there are various categories or causes that we can categorize them into different groups. For example, let us look at about 4 of them. The first one, we have the 46XXDSD. That's a category or a group of these differences of sex development, or a group of intersex. So the second one, we have the 46XYDSD. Then the third one, we have the overtesticular DSD. Then we have the last one, complex or undetermined DSD. Those are the 4. The 46XXDSD, 46XYDSD, then we have the overtesticular DSD, then we have the undetermined or the complex DSD. Let's look at them one by one. The 46XXDSD. Here, a person has the XX chromosome, which is typically seen in female, with even ovaries present, but the external genitals appear as that of a male. And most often, this is as a result of female fetus that have been exposed to excess of male hormones before birth. And therefore, the labia, which is the lips or the fold of the skin of the external female genital, will fuse together and then grow together. At the same time, we find that the clitoris enlarge and appear like a penis. And therefore, in conclusion, we are saying in most cases the person will have a normal uterus, normal fallopian tube, normal ovary, but then externally they have something that appears like a penis. And this condition we can also call it 46XX with virilization. Now, virilization is also known as masculinization. Here, a female develops male characteristics, or a newborn that has signs of male hormone exposure at birth. That genetically you're female, but then you begin developing characteristics of male, or a newborn at birth who has a sign of excessive exposure of male sex hormone. And causes of the 46XXDSD type of intersex people, here the causes we can list some. We have congenital adrenal hyperplasia, which is the most commonest cause of this DSD. We have the male hormones such as the testosterone that is either taken or encountered by the mother during pregnancy. Then we have male hormone producing tumors in pregnant mothers. Most often this hormone is the ovarian, I mean most often this tumor is the ovarian tumors. Then we have aromatase deficiency. uh, for aromatase deficiency might not be noticeable until puberty. Now we should know that aromatase is that enzyme that converts the male sex hormone to female sex hormone. Therefore, if you have too much activity of aromatase, there's going to be excess of female sex hormone, the estrogen. But when we have too little of aromatase activity, we may end up with 46XX-DSD. So at puberty, these children who are XX, who have been raised as girls, may begin to develop or take on male characteristics. Let's go to the second one, that is 46XY-DSD. So for the 46XY-DSD, the person has the XY chromosome, which is typically seen in male, but externally the genitals are either incompletely formed, it can be ambiguous, or it can be purely a female genital structure. And we should note that internally the testes may be present and normal, or it might be malformed, or it might even be absent. But that is internally, but physically they might have something which is similar to that of a female. And then we should note that this condition can also be called 46XY with undervirilization. Now, undervirilization is the opposite of virilization. Now, in undervirilization, we have a person being genetically male, but his body is unable to produce enough male sex hormones, and that will result into female characteristics. Then we can go to causes of this 46XYDSD. Now there are a number of causes. Let's list some. For example, number one, we have where someone has problems with the testes. That the testes produce male. The testes work is to produce male sex hormones, but where you have the testes that have not formed well, it will lead to undervirilization. For example, in the case of XY pure gonadogenesis. Then we have number two, where someone has a problem with testosterone formation. Uh, Testosterone is the male sex hormone, but its formation has a series of steps, and each of these steps involve particular enzymes. And where you have deficiency in these enzymes, or you have problems with these enzymes that are involved in the various steps of formation of this testosterone, you will end up with a deficiency of testosterone, and this deficiency or the inadequate testosterone will produce a different syndrome of 46XY-DSD. And also different types of congenital adrenal hyperplasia can also fall under this particular category. Then maybe the third one is where you have a problem using problem with using testosterone, that here one can have normal testes and make even adequate amount of testosterone, but will still have the 46XY DSD. How does it happen? We have two conditions under which this can happen. The first condition, we have the 5 alpha reductase deficiency. Then the second condition, we have the androgen insensitivity syndrome. Let's look at them one by one. We can start with the 5 alpha reductase deficiency. That people who are having this particular form of deficiency lack the enzymes that is needed to convert testosterone to its active form, the dihydrotestosterone. And at least 5 different types of alpha or 5 alpha reductase deficiency have so far known. So some of these babies who have this uh, particular problem, the 5 alpha reductase deficiency, may have a normal male genitalia, or some may have normal female genitalia, or some can have something in between. But the issue is this, that the changes to the male genitalia will always start at time of puberty. It normally starts at time of puberty. Then the second condition is the AIS, that is the androgen insensitivity syndrome. Uh, it is the most commonest cause of 46XY DSD. We should note that. And in this situation, that the hormones are all at normal levels, but that you produce the hormones normally, the levels are okay, but the receptors to the male hormones don't function properly. And we should note that over 150 different defects have been isolated so far, and each will cause a different type of AIS. So these are too many, meaning even the number of people who are having it is going to be so many, because when you look at statistics, it says about 1.7 to 1.9 people percent of the population are intersex people. Let's look at the next category of intersex or differences of sex development. We have the ovotesticular DSD. Here, a person has both testicular and ovarian tissues, and it may be within the same gonad. That is to say, we have ovotestis, or the person might have one ovary, one testis. That is for the ovotesticular DSD. But a person may also have, when you get into chromosome level, the person might have the XX chromosome, or he may have the XY chromosome, or he can even be having both. Now, the external genitals may appear ambiguous, or it may appear male or female. That's with this ovotesticular DSD. But unfortunately, the causes of testicular DSD is not known. Most of their causes are not known. That's the unfortunate bit of it. Then we can look at the fourth one. We have the complex or the undetermined DSD. And here we are saying that many of the chromosome configurations that is different from the simple ones that we know, the 46XX and then the 46XY chromosome configuration, will always or can result into disorders of sex development. And these configurations include the 45XO, where you only have the X chromosome. We have the 47XY, I mean the 47XXY chromosome configuration. Then we also have the 47XXXX, 47XXX chromosome configuration, where each of these is having an extra chromosome of either I mean an extra X or an extra Y chromosome. But these disorders are in this way that they normally don't result into a condition in which there is a typical discrepancy between the internal and the external genitals, but there may be abnormalities or imbalance of the sex hormones, and this is because of the extra sex hormones that are there, that you may not see a physical mismatch between the internal and the external genitals, but then there might be, or there might be problem with sex hormone levels and overall sex development due to altered numbers of sex chromosomes. Those are the four categories of differences of sex development or the intersex people. So what happens is this, that we have interventions that are done onto this particular group of people, but these interventions come with their own challenges, because back then we had it in medicine that when you have newborn with ambiguous genitals or genitalia, they represent a medical emergency which requires prompt investigation and early gender assignment. But then, as the world keeps evolving, the world is coming up and saying, no, maybe we can wait with these hormone and surgical therapies until these people are at ages where they can think and make choices depending on how they are growing and how they feel more comfortable. Because let me tell you, for the surgical bit of it, we would intervene in two ways: that we have the feminizing genitoplasty, and then we have the masculinizing genitoplasty. because for the feminizing genitoplasty, here we have surgical repairs for those infants who are to be raised as female. That is for the feminizing genitoplasty. For children whose parents have decided with the doctors that they would be raised as females, they would do a number of feminizing genitoplasties or surgical repairs or procedures. For example, we have one where it involves removing the corporal bodies with preserving the glands and its innervations uh, to leave a clitoris with normal sensation. That is one. Then we have the second one, which would involve creating a normal looking introitus and labia minora and majora. That is still surgically done. Then we have the third one where we have vaginoplasty to provide adequate opening for the vagina to the perineum. Then we also know it that until the 1960s, clitoridectomy has been the principal surgical procedure for people with clitoral hypertrophy. These are all under feminizing genitoplasties. Those are surgical procedures. Then we have the masculinizing genitoplasty, where we have we would say masculine reconstruction involving we have orchidopexy, we have hypospadia repair, we have removal of retained Mullerian duct, we have removal of retained Mullerian duct structures, and correction of the prepenile bifid scrotum. In conclusion, for this masculinizing genitoplasty, we say that all strict gonads or ovarian tissue must be removed for this masculinizing genitoplasty. And we do it for infants who are to be raised as boys or male. But they come with a lot of challenges, these surgical procedures. Then we have the hormonal interventions or the hormonal therapy. We could list a number of them because we have, like, for those people who are having salt wasting congenital adrenal hyperplasia. First of all, we should note that this one here is a severe form of a rare genetic disorder that causes adrenal glands to produce too little of aldosterone, and we know the function of aldosterone, therefore causing their body to be unable to retain enough sodium. What we are saying is too much of this sodium is lost in urine. That's where it gets its name, that salt wasting congenital adrenal hyperplasia. So in this particular kind of condition, hormonal therapy becomes life saving because hormones that are necessary for survival, like cortisol and aldosterone, get replaced. But in contrast, other hormones, that is to say the androgens or mineralocorticoids, are secreted in excess amounts due to hormonal imbalances. Even when we know that this hormonal therapy is to suppress the unwanted excess by exerting a negative feedback, that is for salt wasting congenital adrenal hyperplasia, that the hormones that is needed to retain these sodium ions in our body can be replaced, and that's so life saving. But when it comes to the sex hormones, we fail to control them as they would naturally be controlled. Then in the second scenario, we have for those who have many causes of hypogonadism. Here, sex hormone replacement is prescribed to stimulate sexual development, growth of hypoplastic penis in young boys. We have pubertal changes of male or female. We have psychosexual development. We have adult behavior, and there's even additional benefit that is seen in bone mineral density when these hormones are prescribed. Then we have in the third category, where we are saying we do hormonal therapy in treating unborn children. That is to say, prenatal dexamethasone that is given in treatment to pregnant mothers. We do prenatal dexamethasone treatment administered to pregnant mothers to prevent ambiguous genitalia formation in females with 21 hydroxylase deficiency. And the outcome studies show that it is well tolerated with general efficacy. There's well tolerability of this particular procedure, and it is highly efficient. And the practice has been there for over 20 years. That's for the hormonal therapy. But we find that even with the hormonal therapy and the surgical therapies, intersex conditions are very difficult to manage. And we should note the following, that this management may intrinsically perturb complex aspects of a person's gender identity, gender role behavior, sexual orientation, sexual function, and psychological adjustment. That's why you want to wait until they can choose. Then we also should agree that decisions that are made about someone's sex by a doctor and a mother when this person is an infant have always not turned out to be the most correct choices, uh, because this person may grow up feeling uncertain about his or her gender identity, or even worse still, they may have a sense of outrage about their life and treatment experiences. But the world has come to believe that these intersex people may have a definite views about hormonal therapy or surgical therapy if given time, until when they can think and make choices under skilled counseling with a multidisciplinary team. So the world is saying maybe we need to wait for these people to grow, reach particular ages when they can decide, depending on how they are growing. If they are growing up feeling more of male or feeling more of female, it is them to decide. What you would do is to explain to them the available procedures or options, and then they would choose. That's what the world is trying to say right now. But in general, or in conclusion, this particular group, the intersex people, do not choose how they are born. When you look at the science of it, the medicine of it, they don't choose how they are born. So when you begin to segregate them, you begin to stigmatize them, it is really not fair. And I think we need to step up the game and maybe inform the community that this kind of people are with us not because there's witchcraft, not because of certain sins the parents or them committed, and they should be treated like any other person. Let them receive all services like they are part of us, and stigmatizing them really doesn't help. But we could involve them, treat them the same at school with any other children, treat them the same at hospital, at police, prisons, like the judiciary. People need to step up the game and help this particular community, because these are things you don't have control over. So it might not be in your family right now, but you never know what happens tomorrow. These 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 errors that happen at genetical levels are not chosen. They just happen. You can't call for them. So as we advocate for rights of other people, like people with disabilities, people without disabilities, this particular group of people don't deserve to be discriminated as they are being